Mic on? Mic on? Mic one, mic one, mic one. Mic one, mic one, mic one.
Yeah. Some water?
Sure. Sir. Oh, yeah, no, I think Joe Larson converted.
Well, it makes a tremendous amount of sense. You know, the lung map, they're starting to, like in the interstices, really, they can almost do biomarkers.
Yeah.
Because you have a captive patient, you have a trained clinician, so, you know, that would be an opportunity to vet diagnostic tests and so forth. So it's set up some
Yeah.
standing.
Well, I mean, particularly somebody who's supposed to be antibiotic hasn't heard about it. Negative experience.
Mm-hmm.
Adolescent.
Yeah. How are you? Pardon me? Yeah. I think so. Mm-hmm. Yeah. Yeah, we have a huge scope of things for continuous manufacturing, shortage drugs. So, what a nice partnership. Yeah. Yeah, I just thought you were.
Did you get to the gym this morning?
No, I did not. Did you?
No, I wish I had. I'd go on the way after getting out of here. If we have anything left in us.
Yeah, I was just lamenting walking up. Today would have been a spectacular day to bike
Oh,
in.
yes.
I try to do that once a week at least, or if I can.
Do you have an exercise program?
What's that?
An exercise program.
Not when I can, between 3 kids and a terribly busy job.
Right.
Do you have any big plans for the summer?
For the summer?
I just said any big plans for the summer?
A 1-week vacation with the family. That'd be nice.
Going and
Just to the Eastern Shore.
you guys have a place over there? Or?
No, we rent the same place every year. How about you?
Yeah, my parents are having a 50th wedding anniversary on July 1st, so we had a big family reunion.
That's
All
awesome.
Siblings, nieces and nephews, and grandnieces and grandnephews coming in. So that's kind of the big to-do. And then my wife is kind of good in, her folks have a place in North Carolina on the coast, and so she's going to take the kids down for a couple of weeks. I'll see if I can sneak away for at least a few days.
Oh, do a week. Got a laptop. You have a
Exactly.
Wi-Fi signal there?
Yeah.
That's all you need.
That's what my wife's doing. She's telecommuting from the beach.
That's what my oldest daughter's going to do. She's going to telecommute for part of the week.
She live around here? Or?
Yeah, she's in Georgetown Law School. Night school. Works full-time in the daytime.
Oh boy. Well, she have any kids? Or?
No, she just got married in August, so starts to pack it all in at the same
Seems
time.
like good to.
It all fell together quickly for her. And she tells me in January she was just named editor-in-chief of the Georgetown Law Review. What's somebody trying to do? Kill you?
Oh my God, that's fantastic.
Yeah, it is awesome. It's like the, so I looked it up, and it says this is the one law journal you find in every law school in the country.
Yeah.
Can you imagine trying to coordinate that? Go through your second year of law school, start a new husband,
And start a new husband and have a full-time
full-time
job.
job.
No. That's
Yeah.
did she take a few years between undergrad and?
Yeah, she did. She went to journalism school at Maryland. I worked 4 years as a journalist.
Stayed for a couple rounds.
Good morning. Meeting here of the Energy and Commerce Subcommittee on Oversight and Investigation. I do want to announce to members this hearing is here and not in room 2123. I just want you to know. I was there. You were not. It was a very powerful, moving.
There was a very long line of folks to get in.
There was. It was. So I figured it must be this hearing, but my apologies. That happens. So this is a hearing on U.S. public health response to antibiotic resistance. The subcommittee convenes this hearing today to examine public health responses to the challenge of antibiotic-resistant superbugs. One of the world's most pressing health problems is the emergence of bacterial infections that are resistant to antibiotics. And according to the Centers for Disease Control and Prevention, each year 2 million Americans become sick with antibiotic-resistant infections, and of that, about 23,000 die. Globally, some institutions estimate up to 700,000 die each year from antibiotic-resistant infections, and without action, the researchers estimate 10 million people will die per year by 2050 from drug-resistant infections. The World Health Organization has declared that humanity is on the precipice of a post-antibiotic era, where common infections may once again be lethal because bacteria have become resistant to the antibiotics existing to treat them. The antibiotic resistance threat just got greater. Last month, a woman in my home state of Pennsylvania was diagnosed with an E. coli infection that had a rare gene called MCR1, a new kind of superbug, never before seen in the United States. Medical professionals were alarmed for 2 reasons. One, this new superbug is resistant to colistin, an antibiotic of last resort, which is used when no other antibiotics can fight the infection. And 2, this MCR1 gene can move from one bacteria to another. Eventually, MCR1 could merge with another superbug that is resistant to all antibiotics except for colistin and form an unstoppable superbug. In response to the discovery of the MCR1 gene, CDC Director Dr. Tom Frieden commented that the medicine cabinet is empty for some patients. It is the end of the road unless we act urgently. If this threat is not stopped, minor infections may become life-threatening, and treatment for diseases such as cancer, diabetes, or routine surgeries will be at risk. Fortunately, the end of the road is not here yet, and Congress and federal agencies are working diligently to counter the effects of antibiotic resistance. These efforts confront the 2 main contributors to the spread of antibiotic resistance: the overprescription of antibiotics and the lack of new antibiotic development. Since the discovery of penicillin in the early 20th century, almost every type of bacteria has become less responsive to antibiotics. As soon as an antibiotic goes into wide use among the general public, bacteria evolve to become resistant. A study published last month in the Journal of the American Medical Association, known as JAMA, found that nearly 1/3 of antibiotics prescribed in doctors' offices, emergency rooms, and hospital-based clinics in the United States are not needed. This amounts to nearly 47 million unnecessary prescriptions given out each year. That's 47 million unnecessary prescriptions each year. And the number in this report most likely undercount the use of antibiotics because the data did not include urgent care clinics, retail pharmacies, dentist offices, and prescriptions given over the phone by nurse practitioners and physician assistants. To combat antibiotic overuse, the CDC has partnered with the FDA to advocate for antibiotic stewardship programs in healthcare facilities throughout the United States. The CDC has issued guidelines about how hospitals can minimize inappropriate or excessive use of antibiotics, which could help reduce antibiotic overprescription. Reducing the inappropriate use of antibiotics will help, but it can only slow the spread of antibiotic-resistant bacteria. New antibiotics and alternative therapies must be developed. Despite the need for antibiotic development, as of March 2016, there were only 37 new antibiotics in development, and just 13 were in phase 3 clinical trials. These drugs would potentially address many resistant bacteria, but they are not enough. To combat this, in February of this year, the Biomedical Advanced Research and Development Authority, known as BARDA, has collaborated with NIH to establish a biopharmaceutical accelerator that will support research and development to incentivize antibacterial drug development. This accelerator will, 1, fund development of antibacterial products, and 2, quickly move successful drug candidates to early development, 3, provide business and drug development guidance, and 4, decrease barriers to research and development of antibiotics. The CDC, FDA, NIH, and BARDA have and continue to make significant and ongoing contributions to implement the National Action Plan for Combating Antibiotic-Resistant Bacteria released last year, which outlines steps to implement a national strategy to combat antibiotic resistance. Additionally, Congress has increased funding for these initiatives by 57% over last fiscal year for a total of more than $375 million. Despite these promising developments, we are facing a public health challenge, and we need to ensure that the federal government is taking the appropriate action to protect the American public. So I want to thank the witnesses for appearing here today before the subcommittee. I look forward to hearing all of your testimony on this very, very important issue. And I now recognize the ranking member of the subcommittee, Ms. DeGette of Colorado, for 5 minutes.
Thank you so much, Mr. Chairman. This is a really important hearing. We've been worried for quite some time here in Congress and at the agencies about the risk of resistant antibiotics. And this report last month about the superbug has been quite concerning to all of us. The bacterium's resistance to colistin is particularly concerning because in this country, physicians use colistin as the treatment of last resort when other antibiotics are no longer effective. Public health experts fear that this gene could jump to other bacteria that are already resistant to most other antibiotics. Here's another observation about Dr. Frieden. He said, it basically shows that the end of the road isn't very far away for antibiotics, that we may be in a situation where we have patients in our intensive care units or patients getting urinary tract infections for which we do not have antibiotics. Obviously, we're all concerned about this, and I know all the witnesses and the members share this concern. We really don't want to revert to a time when physicians no longer have the tools to treat infections. Even common and once easily treated infections could once again prove life-threatening. That this newest superbug has emerged on our home turf should not surprise us. Public health and infectious disease experts have been sounding the alarm for years, but I hope that this new discovery will lend urgency to efforts to monitor and fight antibiotic resistance. The CDC has reported for decades that overuse of antibiotics and poor hygiene practices in hospitals and other inpatient healthcare settings contribute to the formation of drug-resistant bacteria. For example, studies showed that 30 to 50% of antibiotics prescribed in hospitals were unnecessary or inappropriate. Public health experts have similarly warned us about overprescribing of antibiotics in outpatient settings. A recent Pew study, for example, found that about 13% of all outpatient office visits in the U.S. result in the prescribing of an antibiotic, but 30% of those, which is almost 50 million prescriptions, are unnecessary. Now, in the last decade, these issues have received increased attention and funding, but as our witnesses will testify today, there's still far more to do. And I want to hear from our witnesses in particular in two different areas. The first one is antibiotic stewardship programs, which can both decrease the spread of infections and reduce the inappropriate use of antibiotics. We need to improve public health education to ensure that patients and physicians understand how and when antibiotics should be prescribed. We need such stewardship programs both in healthcare facilities like hospitals and also in communities. I'm hoping I can hear from our witnesses about antibiotic stewardship and whether we are seeing positive outcomes from current efforts. I also am interested to see how antibiotic stewardship programs can result in more appropriate and effective use of antibiotics in animals. I think more needs to be done to shed a light on these issues, and I'm interested to see what the witnesses will have to say. I do wish that we had a witness from the USDA, because antibiotic overuse in animals is a really big problem. The second area I want to hear about is the development of new antibiotics, diagnostics, and even vaccines to address the issue of antibiotic resistance. All of these agencies today play a critical role in the development of new drugs and other tools. I can't use this opportunity in this hearing. I can't lose the opportunity to talk about our wonderful bill that Chairman Upton and I have co-sponsored, along with all the other members of this subcommittee. Earlier this year, the 21st Century Cures Act passed out of the Energy and Commerce Committee unanimously and was then passed by the full House on an overwhelming basis. The bill includes the text of the Antibiotic Development to Advance Patient Treatment Act, or ADAPT Act. This is a really important bill that was originally co-sponsored by Congressman Jean and Congressman Shimkus, and it creates a new FDA approval pathway for limited population and antibacterial drugs. This legislation is designed to provide an approval process for drugs that affect a limited population of patients with serious or life-threatening infections, or for drugs that fill an unmet need. We really need to pass the ADAPT Act. The easiest way to do this is, of course, for the Senate to pass the 21st Century Cures Bill, and frankly, we keep hearing assurances that this will be happening any day. So maybe this urgent issue can be used to help enact this important law into law. So, Mr. Chairman, I really want to thank you for having this hearing. It's an important one, and I want to thank our witnesses again for coming today, and I yield back.
Generally yield back now. Recognize Chairman of the full committee, Mr. Upton, for 5 minutes.
Well, thank you, Mr. Chairman. So today we gather to discuss the U.S. public health response to antibiotic resistance in light of the recent discovery of a new superbug. This superbug gene, first discovered by Chinese and British researchers in pigs, raw pork, and a small number of folks in China in November of last year. But a recent case, of course, of the woman in Pennsylvania with the E. coli is the first discovery of this rare gene, known as MCR here in the U.S. Headline in the Post captured the urgency. The superbug that doctors have been dreading just reached the U.S. Concerns about this new threat are real, indeed, and they are being felt in Michigan and throughout the country. The detection of this new antibiotic-resistant gene is very troubling because it signals the potential arrival of an unstoppable superbug. The gene is resistant to a last resort antibiotic and has the ability to move from one bacterium to another. While MCR1 on its own is treatable by other antibiotics, disease experts tell us that the fear is not if, but when this gene transfers and merges with another superbug that is resistant to all other antibiotics. This would create the nightmare scenario of a bacterial infection that cannot be stopped with any known antibiotic treatment. The continuing evolution of bacteria, the overprescription of antibiotics, and the lack of new antibiotic development have all contributed to the problem. Our understanding of the MCR1 gene is growing by the day, but there are still many questions that remain to be answered before we can be assured that we're doing everything that we can to protect the American people from this superbug and future challenges that arise from antibiotic resistance. The questions include, how did the bug get here to the U.S.? Where did it come from? How does it spread? Are we prepared for an outbreak of antibiotic-resistant bacterium? What is the federal government's plan to confront the public health challenge? In addition to our concerns about this particular superbug, we need to take a look at antibiotic resistance as a whole. And in response to the discovery of MCR gene in Pennsylvania, Dr. Frieden commented that it basically shows us that the end of the road isn't very far away for antibiotics. If that's true, minor bacterial infections could suddenly become fatal. So we need to evaluate antibiotic development and assess where the science is, what barriers exist, how do we promote the discovery of new antibiotics. And as my good friend and colleague Ms. DeGette said, through the GAIN Act of 2012 and the ADAPT Act, which is part of 21st Century Cures, this committee has made a good number of strides to foster and encourage the development of new antibiotics that can fight the superbugs. In the meantime, we need to take appropriate measures, such as antibiotic stewardship program, to ensure that the antibiotics that already exist are being prescribed appropriately. Appreciate the testimony and the dialogue with our experts, and I yield back to Mr. McKinley.
Thank you, Mr. Chairman. Antibiotics, it's my understanding, I'm the engineer in the room, not the practicing physician on it, but my understanding is that the antibiotics are not effective against viruses. And this seems to be a good scientific fact from which to begin with. But yet in America, you've heard the statistics, a third of the antibiotics are overprescribed by doctors. The CDC said that 47 million prescriptions were unnecessarily prescribed or inappropriately prescribed for conditions that don't respond to the antibiotics. And then the other point comes to it is that we only represent 5% of the population of the world. So we've got 95% of the world out there. In many respects, we know there are 20 nations in Europe, and we know Mexico issue antibiotics over the counter. And that tends to get to a point where we're probably going to overprescribe, or they're going to be inappropriately used, and our body will be able to build up resistance to that as a result of this inappropriate use for that. And then we go to this fast forward to today with the woman in Pennsylvania. The interesting part is going to be is how we're going to respond to that, because how did she get it, and what are we going to do to respond to that? So watching the time frame with this, we don't know if these antibiotics are used to help will even be effective in the future because of this overuse, overprescription. So looking forward to this, your testimony today, and I yield back the balance of my time to Dr. Burgess.
I thank the gentleman for yielding, and I do want to thank our panelists for being here today, and I'm most interested in knowing how you all are going to be working together on an interagency basis to see that we achieve the goals. I'd like to hear from you perhaps some of your thoughts on what the legislative branch might do in addition to getting the Cures Bill passed over in the other body. And then finally, there was a significant amount of money made available in this area last December, and I would like to hear from each of you how that money has been allocated and utilized, and as to whether or not you thought it had been of any benefit. Thank you, Mr. Chairman. I'll yield back.
Thank you. I now recognize the Ranking Member of the Full Committee, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. Antibiotic resistance is a significant domestic and global threat to both public health and national security, and I'm glad we're taking the opportunity to examine this issue. I want to begin by emphasizing that antibiotics are incredibly valuable tools that have made once fatal infections easily treatable, and antibiotics have transformed our healthcare system. But as the use of antibiotics has spread, the threat posed by antibiotic-resistant bacteria or superbugs has grown. Without effective, coordinated, and decisive government action, we risk entering into a post-antibiotic world where common infections could once again become life-threatening. The recent discovery of the MCR1 gene on a colistin-resistant strain of the E. coli bacteria signals that this day is closer than it's ever been before. We see alarming statistics about the rates of overprescribing of antibiotics, both for unnecessary and inappropriate use. And at the same time, we have seen that drug manufacturers are unable to produce enough new drugs to meet this threat. There's no question that our arsenal of effective antibiotics is dangerously low today as a result of antibiotic resistance, and it is a dire situation. That said, I'm encouraged by the attention and funding we have placed on antibiotic resistance in recent years. Last year, the White House unveiled this National Action Plan for combating antibiotic-resistant bacteria, which sets forth ambitious goals to fight antibiotic resistance. All the agencies before us today play critical roles in that effort. In fiscal year 2016, we're devoting over $830 million to fighting antibiotic resistance, and President Obama has requested $1.1 billion towards this effort for fiscal year 2017, and these are important investments. But in order for us to effectively address antibiotic resistance, we need to make this a priority for the foreseeable future. This is not an issue we can address for a few years and then ignore. Antibiotic resistance is a reality of nature. Bacteria begin to mutate and develop resistance as soon as a new antibiotic begins to be used. We must develop long-term strategies and guarantee long-term funding to fight antibiotic resistance. And once we've begun implementing those strategies and ramping up funding, we must follow through on our commitments. It's also important to emphasize that this is a global threat. It's not enough to address resistance here in the United States and hope that it'll keep us protected. And from a global perspective, we must recognize that we're only as strong as our weakest link. In some places, antibiotics we use sparingly in the United States are available over the counter. In many countries, a lack of hygiene, sanitation, and basic infection control in medical settings results in increased antibiotic consumption. If we do not want these superbugs here in the United States, we need to stop them from developing both here and abroad, and we must also improve global surveillance of antibiotic-resistant bacteria and antibiotic consumption. Stopping the spread of anti-resistant bacteria is a global threat, and therefore solutions must be global in nature. So I just want to thank the witnesses, look forward to the promising work at each of your agencies and how we in Congress can be your partners in moving forward. And I yield my remaining time to Mr. Green of Texas.
Thank you, Mr. Chairman. Thanks for our ranking member for yielding to me. As said before, researchers have found a person in the United States carrying bacteria resistance to antibiotics as a last resort. An alarming development could mean the end of the road for antibiotics. For years, scientific leaders across the globe have been warning of what could, if we don't take swift, aggressive action, a post-antibiotic era in which modern medicine we take for granted is no longer safe because we will not be able to control infection from childbirth and surgery to dialysis and chemotherapy. Even simple cuts and wounds could be an increased risk of turning fatal without effective antibiotic treatments. Alarmingly, at a time when resistance is rising, the pipeline for new antibiotics is dried up. Resistance can and must be slowed, but it cannot be stopped, and we need the new classes of antibiotics to combat drug-resistant antibiotics. The public value of antibiotics is difficult to overestimate, yet there's a widely acknowledged market failure when it comes to antibiotics. We need meaningful research incentives, strong public-private partnerships, and flexible clinical trials. That's why not only myself, but our committee championing the ADAPT Act that passed in the 21st Century Cures that would enable the FDA to work with sponsors and reduce regulatory barriers to antibiotic drug development. ADAPT offers one tool Congress can enact to address the lack of effective treatments against superbugs. I look forward to hearing more about that proposal and other ideas Congress should consider and the ongoing efforts to address this public health crisis. And I'll yield to back my 14 seconds.
Gentleman yields back. I ask unanimous consent that the members' written opening statements be introduced into the record, and without objections, the documents will be entered into the record. I'd now like to introduce the witnesses of our first panel for today's hearing. The first witness on today's panel is Dr. Beth Bell. Dr. Bell is the director of the National Center for Emerging and Zoonotic Infectious Diseases with the CDC. We'd also like to welcome again Dr. Janet Woodcock. Dr. Woodcock is currently director of the FDA's Center for Drug Evaluation and Research. Our third witness on today's panel is Dr. Richard Hatchett. Dr. Hatchett is currently serving as acting director for the Biomedical Advanced Research and Development Authority within HHS Office of the Assistant Secretary for Preparedness and Response. Our final witness is Dr. Dennis Dixon. Dr. Dixon joins us from the NIAID's Division of Microbiology and Infectious Disease. I'd like to thank all the witnesses who are appearing before the subcommittee today. You are all aware that the committee is holding an investigative hearing, and when doing so, it has the practice of taking testimony under oath. Do any of you have an objection to taking testimony under oath? The chair then advises that you are under the rules of the House and the rules of the committee. You are entitled to be advised by counsel. Do any of you desire to be advised by counsel during the testimony today? Seeing no request for that, in that case, will you all please rise, raise your right hand, and I'll swear you in. You swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? I do. Thank you. All the witnesses have answered the affirmative, and you are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We'll have you each give a 5-minute summary of your written statement. Please pay attention to the timing. And turn the microphone on and bring it as close to your mouth as you can. Thank you. You may begin, Dr. Bell. You're recognized for 5 minutes.
Thank you. Good morning, Chairman Murphy, Ranking Member DeGette, and members of the subcommittee. I am Dr. Beth Bell, Director of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention, and thank you for the opportunity to testify before you today. CDC works 24/7 to save lives and protect people against health threats, including the threat of potentially untreatable infections. With support from Congress, CDC is working to improve the nation's capacity to detect, respond, and prevent antibiotic-resistant threats in healthcare settings and across communities to protect Americans and save lives. Using the resources provided by Congress in FY 2016, CDC is working on 4 fronts to support transformative improvements in our national capability to identify and respond to antibiotic resistance. First, CDC will invest the largest portion of this funding in our 50 states, 6 largest cities, and Puerto Rico. CDC will support state activities to improve the detection and prevention of AR infections transmitted across healthcare and community settings. These are just-in-time investments as the pace and challenges of antibiotic resistance are accelerating, and every state needs capacity to take appropriate action. Second, CDC's antibiotic resistance lab network will provide infrastructure and lab capacity through 7 regional labs across the country. These labs will be able to detect resistant organisms recovered from human samples and new forms of antibiotic resistance. CDC will also provide support for labs in all states to test for CRE, the nightmare bacteria. Third, CDC's Advanced Molecular Detection Initiative is another important tool in our efforts to identify and solve more outbreaks faster. Because of innovations developed through this AMD initiative, CDC will be able to scale up whole genome sequencing of multiple foodborne pathogens to better understand foodborne antibiotic resistance patterns. Through the National Antimicrobial Resistance Monitoring System, NARMS, sequences from animals, from retail meat, and from humans will be compared to identify new ways of preventing human infections. Finally, our ability to reduce antibiotic resistance will depend in part on improving antibiotic use, and we are working towards that through better measurement, through expansion of stewardship programs, and through educational campaigns. The administration's budget request for FY 2017 includes an increase of $40 million for Year 2 of CDC's Antibiotic Resistance Solutions Initiative. And so in FY 2017, in addition to sustaining AR capacity started in 16, CDC will expand state antibiotic resistance prevention programs to better respond to outbreaks, to improve prescribing, and prevent antibiotic-resistant infections across all healthcare settings. These collective investments have a direct impact on the response to the AR threats, including the emergence of the MCR1 gene in the United States. In May, Department of Defense scientists announced the first discovery of the MCR1 gene in bacteria isolated from a person in the United States. Although there is not an immediate threat to the public or the current health of this patient, this is an important development for the United States. The antibiotic colistin is used as a rescue drug to treat patients with multi-drug resistant infections like CRE. The MCR1 gene makes bacteria resistant to colistin. The gene exists on a plasmid, which is a small piece of DNA that is capable of moving from one bacterium to another, spreading antibiotic resistance among bacterial species. The presence of the MCR1 gene and its ability to share its colistin resistance with other bacteria, such as CRE, raises the possibility of a bacteria that is resistant to every antibiotic. USDA also discovered MCR1 in E. coli isolates collected from 2 different pig intestines. By comparing the DNA sequences of all 3 isolates, federal scientists have determined that the isolates from the pigs are different from that from the human. Yesterday, CDC issued an alert to proactively notify states, hospitals, and clinical laboratories about the availability of new detection tools for MCR1 and to reiterate recommendations for infection prevention, environmental cleaning, and reporting to public health. The identification of MCR1 vividly illustrates our domestic and global challenges of antibiotic resistance. MCR1 was first identified in China in November of last year, and in less than 6 months has been identified in a human and 2 animals in the United States. Antibiotic use anywhere can potentially affect any one of us. The emergence and reemergence of health threats, including those caused by antibiotic-resistant bacteria, is something we can expect to continue to see in the future. If we lose antibiotics, we could lose the ability to effectively treat sepsis and to provide the care to cancer patients, to organ transplant recipients, or burn and trauma victims. So thank you again for the opportunity to appear before you today, and I look forward to the opportunity to answer your questions.
Thank you, Dr. Woodcock. You're recognized for 5 minutes.
Thank you for holding a hearing on this critical topic. FDA is involved in many fronts in the fight against resistant organisms. We're participating actively in the CARB initiative and collaborating internationally, and also, of course, with our federal partners represented here. Our Center for Veterinary Medicine oversees animal drugs. They have received commitments from the manufacturers of medically important antibiotics to submit supplements by the end of the year. As a result of this, these drugs will have to be prescribed by a veterinarian and can't be used for growth promotion purposes. Our Center for Devices and Radiologic Health regulates in vitro diagnostics or test kits, including antimicrobial susceptibility tests and diagnostics. They're seeing a growing pipeline of rapid diagnostic tests under development. This is very good news. These tests are intended to identify if a person has a bacterial infection or versus a virus, or has bacteria circulating in the blood, or even rapidly diagnose certain types of resistant organisms. So we hope these development programs are successful. They also plan to issue guidance on what they call coordinated development of susceptibility tests. So as we have new antimicrobials approved by Center for Drugs, we could have susceptibility tests also available that could be interpreted by clinicians. Our Center for Biologics regulates vaccines. We know that prevention is the best approach to disease, and of course there are some vaccines for microbial diseases, and we would hope that more are going to be developed. The Center for Drug Evaluation and Research that I head regulates antimicrobials. We've seen the percent of infections treated by common antibiotics shrink over time, as everybody's been saying, as resistance grows. CDER's been actively implementing the GAIN Act that Congress passed several years ago. We've granted 107 qualified infectious disease product designations to 63 different molecules. The designated products can receive fast track designation, and they get a priority review. On approval, they receive additional 5 years of market exclusivity. So this is an incentive, of course. 5 designated antibacterial drugs and 1 antifungal drug have been approved since GAIN was enacted. We continue to work on streamlining drug development. We've issued guidelines. We're trying to lower the barriers, but many of the barriers, as I'm sure we'll discuss, are both either scientific or economic barriers to new antimicrobials. Now, there are further efforts going on in lowering the barriers. I really commend BARDA, who is exploring the use of a master or common protocol. We're working with them, novel ways of studying these that lower the barriers and make some types of studies actually feasible. The 21st Century Cures Bill that was passed in the House contains provisions for the limited population use provision, and the Senate PATH Act does mirror that. We're also very interested in the issue of antimicrobial breakpoints and the use of a more rapid and agile method for changing the breakpoint designations. And finally, though, drug development in this area remains fragile and weak. The incentives that have been put in place apparently are not enough to overcome the scientific challenges that the industry faces in finding new targets and developing these and then actually making money on them. much more needs to be done, I think, to address this threat across all the groups represented here, but the drug development area in particular needs further examination. Thank you.
Thank you, Dr. Woodcock. Now recognize Dr. Hatchett for 5 minutes.
Good morning, Chairman Murphy, Ranking Member DeGette, and members of the committee. Thank you for inviting me to testify about our efforts to combat antibiotic-resistant bacteria. I am Dr. Richard Hatchett, Acting Director of the Biomedical Advanced Research and Development Authority within the Office of the Assistant Secretary for Preparedness and Response. BARDA was established in December 2006 to support the advanced research, development, and procurement of medical countermeasures against chemical, biological, radiological, and nuclear threats, pandemic influenza, and emerging diseases such as Ebola and Zika. In 2010, BARDA initiated its broad-spectrum antimicrobials program, or the BSA program, that I'll refer to, and in 2016, Congress awarded BARDA substantial new funding specifically to combat antibiotic-resistant bacteria. The BSA program was established to support the development of new classes of antibiotics for both biodefense and commercial applications. Under the auspices of the program, we now manage 7 public-private partnerships and a pipeline of 9 antibacterials. BARDA's objectives have been to revitalize the antibiotic pipeline, emphasize programs that address the immediate public health threat of multi-drug-resistant organisms, and enhance our biodefense capabilities. We have achieved notable success. Our portfolio is quite mature at this point. 5 BARDA products are in phase 3 clinical development, and 2 have completed the pivotal studies required for FDA approval. Several products show promise for the treatment of infections due to carbapenem-resistant Enterobacteriaceae, or CRE, one of the most urgent threats that we face, and a few have shown in vitro activity against bacteria harboring the MCR1 colistin resistance gene recently identified in a patient in Pennsylvania. And we are working with our international partners. One of our partnerships has facilitated groundbreaking coordination of funding with the EU's Innovative Medicines Initiative to speed the development of a drug called aztreonam avibactam. BARDA also supports the development of improved clinical diagnostics. Without better diagnostics to guide antibiotic therapy, it will be difficult to prevent the emergence of resistant bacteria. BARDA will thus support a diverse set of tools to differentiate viral and bacterial infections, identify resistant infections in the physician's office, and measure antimicrobial susceptibility. BARDA aims to simplify genetic sequencing tools so that they can be used in clinical laboratories for the evaluation of resistant infections. Finally, BARDA and NIH will offer a $20 million prize for the development of truly novel diagnostics for drug-resistant bacteria. We will be announcing more details about this prize later this year. To achieve these goals, BARDA employs innovative partnership models. Within HHS, BARDA has pioneered the use of portfolio partnerships that can advance multiple drug candidates simultaneously. BARDA has established these flexible, cost-sharing business partnerships using our other transaction authority. We have found that portfolio-based funding reduces risk by allowing for the reallocation of resources across activities and among drug candidates as technical and business risks materialize. Clearly, the early-stage antimicrobial pipeline is too thin. To enrich it, BARDA and NIAID are working together to establish an initiative we are calling the CARB Accelerator. Innovation frequently occurs in small biotechnology companies and in academic laboratories with limited resources and expertise to move product candidates forward. In such circumstances, promising early-stage candidates often fail to advance. The accelerator will serve as an incubator for new products and explicitly seeks to improve success rates in the early-stage antibiotic pipeline. BARDA will launch the accelerator in 2016 and support the program for at least 5 years, while NIAID will provide an array of product development support services. Both entities will collaborate in managing the program and its investments through a joint oversight committee. Stay tuned. We certainly will have a lot more to report on this initiative in coming years. In summary, as new forms of antibiotic resistance continue to spread worldwide, the prospect of bacterial strains resistant to all available antibiotics can no longer be ignored. Developing new tools for diagnosing and treating drug-resistant bacteria will be essential to preserving the practice of modern medicine. ASPR and its partners play a critical role in leading the charge against such threats, and we look forward to working with Congress to address the global challenge of antimicrobial resistance. I look forward to addressing your questions.
Thank you, Doctor. Now, Dr. Dixon, you're recognized for 5 minutes.
Chairman, Ranking Member DeGette.
Make sure the microphone's on and pulled close to you, okay?
Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, thank you for the opportunity to discuss antibiotic resistance, a serious and growing global health threat. I'm Dr. Dennis Dixon, and I serve as Chief of the Bacteriology and Mycology Branch in the National Institute of Allergy and Infectious Diseases. The NIAID is the lead institute at the NIH for research on infectious diseases, including research on antibiotic resistance. NIAID's longstanding research efforts in this area aim to understand the molecular basis of antibiotic resistance, as well as to develop specific and sensitive diagnostics, vaccines to prevent infections, and to partner with pharmaceutical industry companies in the development of novel and improved treatments. The recent detection in the U.S. of bacteria resistant to colistin, an antibiotic of last resort, reminds us of the urgent challenge of drug resistance and the need to address its underlying causes. Fortunately, this particular bacterial strain was treatable by other antibiotics. However, the threat remains that this type of resistance could emerge in other bacteria resistant to most antibiotics, making them untreatable with currently available drugs. Through our research mission, NIAID plays a critical role in the administration's National Strategy and Action Plan on Combating Antibiotic-Resistant Bacteria, or CARB. NIAID's antibiotic resistance research portfolio includes basic research on how bacteria develop resistance and cause disease, translational research to develop diagnostics, therapeutics, and vaccines, and clinical research to evaluate antibacterial products and strategies. Additional funding provided by Congress in fiscal year 2016 for CARB have been instrumental to our efforts. NIAID-supported basic research provides the foundational knowledge essential for the development of vaccines to prevent antibiotic-resistant infections and therapeutics to treat them. As part of the CARB initiative, NIAID supports genome sequencing for a national database of antibiotic-resistant bacteria. This database, developed by NIH in collaboration with FDA and CDC, will provide a comprehensive resource for surveillance, epidemiology, and basic research into the mechanisms of antibiotic resistance. NIAID also facilitates product development by providing non-monetary support to researchers, including genome sequencing, access to clinical specimens, drug screening, and animal model testing. These resources provide much-needed support for the field and help to reduce the risk for product developers. We also provide clinical trials capacity for evaluating new antibacterial products and strategies through our Antibacterial Resistance Leadership Group and other clinical trial networks for clinical research on antibiotic resistance. We are currently in the process of expanding this infrastructure. NIAID is also pursuing the development of point-of-care diagnostic tests critical to determining which drugs will be effective against given infections, and recently awarded funding for research projects to develop rapid, sensitive, and specific diagnostic tools. NIAID is working to discover better treatments to treat antibiotic-resistant infections by screening new compounds and optimizing the use of existing drugs. NIAID recently awarded funding for research projects to develop non-traditional therapeutics for bacterial infections and funds clinical studies testing new formulations, dosing regimens, or combination therapies of currently licensed drugs such as colistin. In summary, NIAID is committed to a robust and comprehensive research effort to address antibiotic resistance and is fostering collaborations with partners in academia, industry, and the federal government. NIAID will continue to support promising research to develop and test new antibiotics as well as methods to prevent the further spread of antibiotic resistance. Thank you for bringing attention to this important topic. I'd be pleased to answer any questions.
I thank all the panel for their comments here. I'm going to recognize myself for 5 minutes. Questions. On September 20th of 2000, then CDC Director Dr. Jeffrey Copeland testified before the Senate Appropriations Subcommittee on Labor, HHS, and Education on the emerging national and global problems of antimicrobial resistance and the response by CDC. And at that hearing, the CDC unveiled its plan that targeted drug resistance. In particular, Dr. Copeland testified that a key part of this plan was developing a national campaign to improve physician prescribing practices and educate parents and patients about the proper use of antibiotics. Dr. Bell, despite the CDC's campaign as well as the efforts of others, the overprescribing of antibiotics still exists. So why did the overprescribing and overuse of antibiotics continue even with the CDC's campaign?
Thank you very much, Mr. Chairman. The campaign that I think you're referring to is a campaign which is called Get Smart. And this is something that we've been working on for quite some time, but actually we've had quite a bit of impact. Actually, we've been able to show a decline. This was a Get Smart campaign was really focused on outpatient prescribing, and while we are very concerned about the continued overuse of antibiotics in outpatients, we've actually seen considerable improvements over the years and have been able to show an impact of the Get Smart program. Antibiotic overprescribing and stewardship is a complex issue, and we really need to attack it on many different fronts. The Get Smart in outpatient facilities is just one piece of the puzzle, and we've been really redoubling our efforts in the area of stewardship over the last few years, releasing guidelines for stewardship programs and essential elements for hospitals and for long-term care facilities.
And you see trends changing that is getting through to physicians?
Well, you know, we now know that there is about 40% of hospitals in the United States that have all the elements of a stewardship program, and we've set a target of 100% of inpatient facilities by 2020. There are a lot of positive developments.
But we go back to that number of the huge amount of prescriptions written every year
Yes.
that shouldn't be. So that doesn't sound like it's working to me. I mean, I just want to know what else. We're here to help you.
Yeah.
We're all on the same team here. I know the White House Action Plan in combating antibiotic-resistant
Yeah.
bacteria, it's there. How is that going to be different? What do we see that's really going to get through to people this time?
Well, you know, we really, I think, are just over the last few years really attacking this on lots of different fronts. As I said, the initial Get Smart program was really an educational campaign focused in one area, and now we have many different modalities. We've been collaborating very effectively also with CMS, with the American Hospital Association. CMS will be developing conditions of participation both for hospitals and long-term care that
Will this also,
require.
excuse me, I have to jump in because we're short on time.
Oh, sorry.
Will this also include, and I asked the panelists, will this also include information for patients? I mean,
Yes.
let's face it, people go to the doctor and say, I want a prescription, and says, well, you got a virus, it's not going to work. I want it anyways. And doctors now, especially because they get rated on were you treated satisfactorily, and hospitals then get dinged, they don't get paid as much.
Yes.
And I've heard time and time again, hospitals say, look, we're afraid of these ratings, and so they'll show up in websites, everything else. So what are we doing to
I
combat that?
appreciate your point, and we have been developing a lot of educational campaigns focused on patients, and I think you're right. Our objective would be for patients when they go to the doctor and the doctor wants to prescribe an antibiotic, the patient says, why do I need this antibiotic? Please explain that to me. And we do really need a sea change, and we're certainly working in lots of different ways to educate the patient. The patient really is pivotal in terms of solving this problem.
Dr. Woodcock, it's always good to see you. Why haven't we developed rapid diagnostic testing for bacterial infections yet? And can you tell us about some of the commercial and technical impediments here?
Well, it's just harder than it sounds. I mean, there are a few. We have strep test, and that's great, okay? So there's something where people can differentiate quickly and put people at ease, perhaps that they don't need an antibiotic in an outpatient setting, right? The technology is advancing, and as I said in my oral statement, the Center for Devices is seeing technologies come along in the development pipeline so we expect over the next several years we will see more rapid diagnostic tests in a variety of settings. It's urgent that we try to find some that differentiate bacterial and virus infections. People are working on expression profiles, so you can do a blood test and make that determination, and then you could reassure the patient you don't have a bacterial infection, and that would be very helpful.
Thank you. I see I'm out of time, so I'll recognize Ms. DeGette for 5 minutes.
Thank you, Mr. Chairman.
As I said in my opening, I want to talk about how we can incentivize development of new antibiotics. And as we heard, earlier this year, BARDA and NIAID collaborated to establish the Combating Antibiotic-Resistant Bacteria, or CARB, Biopharmaceutical Accelerator. So Dr. Hatchett, I'm wondering if you can tell me very briefly why this program is important.
Well, thank you, Ms. Gett, for the question. As I said in my opening testimony, BARDA is very concerned. We do currently have a mature portfolio of antibiotics that are close to achieving licensure, but we are concerned that the upstream pipeline is very weak, and
Right.
that reflects the progressive disinvestment over several decades by biopharmaceutical firms not viewing antibiotics as providing sufficient return on investment. The goal of the Biopharmaceutical Accelerator will be, in collaboration with our partners at NIAID, and we've worked very closely with them to structure the accelerator to support that early development, bring resources and capabilities to early-stage innovators to help them move rapidly through the development process and advance those products, hopefully to a point where they can transition to direct support from
And
BARDA.
thank you. And Dr. Woodcock, I want to follow up on this because when you testified before this committee in 2014 about 21st century cures, you talked about this issue of lack of commercial incentives for drug developers, and that being a reason why we don't have new investigational drugs. Can you quickly update us on what the situation is since 2014 with this? Do we have some promising drugs in the pipeline? Are we fixing some of these commercial issues?
There are some promising drugs in the pipeline, but the pipeline is still very fragile. And what we need is not just a few superstars here. We need a full panoply of investment in the research, the basic science, the drug discovery and drug development that lasts, as Dr. Hatchett just said, over decades. Because we don't just need a few antimicrobials, we need a whole continuing platform and range of them for a wide variety of diseases. And we're just not seeing that. Not all of the ones under development are going to succeed. And that's true of all drug development.
So Chairman Murphy and I got a letter yesterday from the Infectious Disease Society of America, and that organization said in their letter that the administration promised to release a report and recommendations on economic incentives for antibiotics, but the report and recommendations have not been released. I'm wondering what the status of that report is and when it will be released.
I don't know, it's not under my purview, but we can get back to you.
I wish you would, thanks, because maybe that can help illuminate. Yes, Dr. Hatchett.
Hey, I just want to mention that Secretary Burwell did ask the Presidential Advisory Committee on Combating Antibiotic-Resistant Bacteria to look explicitly at the issue of necessary economic incentives for the development of antibiotics. That letter was sent to the committee at the end of March, so they are actively undertaking that review.
All right. What do you know anything? Does anybody here know what this report is and when we're going to get it?
That was the report was a internal report at the White House, and I don't know the status of it. You'll have to address the question to them.
Dr. Dixon, can you talk to me about the clinical trials that are going on strategies for using existing drugs more effectively?
Absolutely. Thank you for the question. And it is important not only to develop new drugs, but to optimize the ones we have left. And in fact, we have a clinical trial underway with colistin because we don't know how long it will be before we run out of use of colistin. But knowing how to use it wisely will reduce the risk of emergence of resistance.
Okay.
So we have looked at how the body metabolizes colistin, in other words, pharmacokinetics, to maximize the presence of drug in the blood and maximize the activity of the drug and minimize the emergence of resistance. And so we have completed a study there that helped to inform better dosing of colistin.
Right.
And we're now looking at colistin alone versus colistin in combination with another drug for carbapenem-resistant Enterobacteriaceae, or CRE, and other resistant pathogens.
Thank you.
And so
Thank you very much. I want to ask Dr. Bell a quick question.
about why improved diagnostics are an important part of addressing the threat of antibiotic resistance.
Yes, thank you. As we've been talking, the issue of stewardship is so pivotal to addressing this whole issue of antibiotic resistance. And improved diagnostics, having the capability to be able to differentiate between a viral infection and a bacterial infection right there when the patient is sitting in front of you, would be a really important tool that would help us in all of our stewardship efforts. So we really do hope that diagnostics that can at least perform that basic function will be something that will be available relatively soon.
Thank you so much, Mr. Chairman. I yield back.
Thank you. I recognize myself for 5 minutes. This discussion reminds me a little bit of some of the environmental issues we've been dealing with over the last 5 years. The fact that we only represent such a small part, 5% of the population of the world, yet we consume so much of our energy and what Gina McCarthy from the EPA the other day said, that it makes no difference what we do, it's what happens around the world is what's really going to affect the environment. Notwithstanding all the issues that we've done in rules and regulations. So my question goes back to my opening statement was, when with 95% of the rest of the world perhaps over-prescribing antibiotics, and we don't know what's happening in some other nations around the world. We know 20 nations, at least in Mexico, are over the counter for antibiotics. With this global issue, what should we be doing? We can solve it here, but if indeed the people are coming in that are drug resistant to our antibiotics, what do we do? So if the four of you could just give me a sense, this fight's a global fight, not the United States. Please, Dr. Bell.
Thank you. Yes, you're absolutely right. This is definitely a global fight. These microbes move around the world, and we have to look at this from a global perspective. So we are working in a number of different areas. First of all, we do have a number of really excellent collaborations with the Europeans in the Transatlantic Task Force for Antimicrobial Resistance, which allows us to share information very quickly, develop common standards, and sort of also pool our resources to help other countries around the world. That's a very effective collaboration. You know, the World Health Organization is actually getting serious about antibiotic resistance. The World Health Assembly has passed several resolutions with all nations basically committing to do something about antibiotic use. And so we have to do everything we can to support them.
But even with our education, we're still at 30%.
That's right. It's a hard problem.
40%. So even with our education level here,
that's right. It's a
I'm
hard
troubled
problem.
about other areas, emerging nations,
Yes.
what's happening. So please continue. I'm not sure I'm buying into all the educational part of it. I'm trying to figure what the other solution
Yeah,
is.
no, I think there are many parts of this. It can't just be education. You're absolutely right. We have to have, there have to be national policies, and there have to be national legislation that supports this sort of, antibiotic stewardship around the world. And as I say, I think that there is a fair amount of interest in that. We've been working also a lot on improving detection so that at least we know what's emerging where. And this is something that go ahead, I'm sorry.
Let's go to that point.
Yeah.
Are there nations that are more prone to have problems that we need to deal with
Well,
around the world? Because we're not all equal.
no, we're not all equal, and there certainly are some countries that do have already a significant problem with, for example, bacteria that are resistant to all antibiotics. Colistin, that we've been talking a lot about here, is actually used quite a bit more to treat human infections in other parts of the world. In India, for example, because there are, unfortunately, a large number of patients that show up in intensive care units, for example, that are infected with bacteria that are resistant to all other antibiotics. So this is a larger problem in some other parts of the world. There are some hot spots. And this issue of detection and focusing on the hot spots and knowing where the hot spots are is something that we've been working on. The Global Health Security Initiative includes antibiotic resistance as one of the areas that the countries have agreed to focus on.
Should we be spending more of our monies overseas to try to work those problems out over there?
Well, I think that it would be not wise for us not to focus on our local problem here. If we don't know what's going on here, we're not going to be able to protect Americans. We have to be doing both because we have to be both strengthening our ability to prevent and detect and respond in the United States while at the same time supporting global efforts.
Okay, so two quick questions. One is colistin. Is that a reasonably marketable, affordable drug, or is this something?
No, colistin is a very old antibiotic. It's been around for a long time. As a physician, I hate to prescribe colistin to patients, and really here, actually in any country, doctors really don't want to use it. It has a lot of potential side effects. It has kidney toxicity. It has brain toxicity. So it really is a last resort antibiotic.
Yeah, I'm afraid my time has expired, but thank you very much for your responses. If I could, next line of questioning from Mr. Pallone. 5 minutes.
Thank you, Mr. Chairman. I wanted to ask each of you a question about investment in fighting antibiotic resistance, so I'm going to go through quickly so I can get to each of you. In the last few years, we've seen increased investment in this fight. The President released the National Action Plan for Combating Antibiotic-Resistant Bacteria in March of last year, with ambitious goals for many federal departments and agencies, and I'm encouraged by the over $830 million we directed toward this effort in fiscal year 2016, and the President, as you know, has requested $1.1 billion for fiscal year 2017 for antibiotic resistance. So let me start with Dr. Bell. In your prepared testimony, you noted that CDC has received $160 million in fiscal year 2016 to implement the National Action Plan, noting that, I quote, "These resources are transforming how our nation tackles and slows antibiotic resistance comprehensively, efficiently, and systematically." So just tell me, how will the increased investment requested for the next fiscal year build on this capacity, and why is sustained investment critically important to our success in combating antibiotic resistance?
Thank you. So antibiotic resistance is a problem that's a problem in communities. And so a lot of our funding in 2016, for which we are very grateful to Congress, is being used to fund states and large cities to build their capacity to detect and to respond and to prevent. And so the additional funding in 2017 will go towards being able to go even further in that regard. So we'll be able to fund more states to have the kind of antibiotic-resistant prevention programs. We'll be able to strengthen our laboratory network so that we can look for more types of antibiotic-resistant organisms. And in general, we'll be able to take the kind of investments that we're making in 2016 to more states and to a higher level.
All right, thank you. Dr. Dixon, in your testimony, you noted that the additional funding for fiscal year 16 has been instrumental to NIH efforts. Again, why is sustained investment in fighting antibiotic resistance critical to your agency?
Thank you for the question. We appreciate the additional funding, and we're applying that to such key resources as the National Sequence Database that will inform the sequences and tracking genes like the MCR1 and others. In diagnosis, and going particularly after the problem of diagnostics, which could certainly help to reduce overprescribing once you know whether or not you have a bacterial infection or a viral infection. Advancing basic translational and clinical research overall fundamentally addresses the problems that can help to identify new candidate drugs, new candidate vaccines, and new candidate diagnostics. And to close up, just to say that we are contributing with BARDA the $20 million diagnostics prize to try and draw key manufacturers into the space.
Well, thank you. So, Dr. Hatchett, you work with industry to bring new antibiotics to market. How is sustained investment important to your work, and what message does that send to your private partners? The same question.
Same, yeah, I was going to say, let me address the question of the value of the funding.
Sure.
For BARDA. As I mentioned, we established our broad-spectrum antimicrobial program in 2010. We did that with funding that was provided by Congress for biodefense purposes. And so we were very diligent in making sure that every antibiotic that we were developing had a biodefense application. For better or worse, what that meant was that we had to develop broad-spectrum antimicrobials, which are part of the problem that has contributed to the spread of resistance because of the overuse of broad-spectrum antimicrobials. The funding that Congress provided in 2016 is specifically dedicated to the problem of antimicrobial resistance, and it allows us to think in much more nuanced ways about how we can build up an armamentarium to treat patients who have antibiotic-resistant bacteria. So we can make investments in vaccines, we can make investments in monoclonal antibodies, and alternative therapies. So strategically, it's very important. In 2016, we are making a number of investments. You've heard about the CARB Accelerator. That's a major investment this year. You've heard about the Diagnostics Prize. We're also going to be expanding our portfolio partnerships this year. All of those efforts are going to take years to mature and to convince our industry partners to enter into partnerships with us in an area that they have traditionally viewed as not providing an adequate return on investment. They have to see that sustained commitment of funding over many, many years and recognize that the government is a reliable partner.
Thank you. I'm out of time for you, Dr. Woodcock. Sorry. Thank you, Mr. Chairman.
Thank you. And next, Dr. Burgess from Texas for 5 minutes.
Thank you, Mr. Chairman. Probably of all the members on this committee, I've prescribed the most doses of antibiotics. Dr. Bouchon, who was here, is actually significantly younger than I am. So I think I probably have a seniority on him as far as the doses of antibiotics. And it's worth considering just a couple of historic notes as we talk about this. 1929, Sir Alexander Fleming noticed the zone of inhibition around a mold that had grown on his agar plate, and that led to the development of what we now know as penicillin. But it was really 15 years later when the Pfizer Corporation figured out how to manufacture this on a large scale. So literally making this wonder drug, which previously was kind of a parlor trick, making it available to the masses and having it available to treat our soldiers on the days that they stormed the beaches at Normandy, thus resulting in significantly lower loss of life and limb from those soldiers who took that beach on that heroic day. My grandfather practiced obstetrics. He was an academic physician. He unfortunately died in 1940, so he practiced obstetrics in the pre-antibiotic days, and I always kind of look at that with kind of wonder and amazement. Here was an individual that chose a profession before the development of good anesthesia, blood banks, and most of all, antibiotics, because anyone who has practiced obstetrics knows that without the ability to prescribe good antibiotics and antibiotics that work well, our ability to fix problems has become severely limited. So we want the antibiotics that we have available to continue to work, and we want them to work well. The JAMA article that was referenced is interest, and I thank the staff for pulling it for me so quickly. And just glancing through it, it seems like pharyngitis, otitis media, and sinusitis are the illnesses or the diagnoses that sort of achieve the lion's share of the antibiotic prescriptions, and easy to be critical of the doctors and practitioners who are prescribing those antibiotics. But let us not forget that 130 years before the penicillin was discovered, the father of our country succumbed to an illness that was treatable by penicillin, a complication of pharyngitis, tonsillitis that led to a peritonsillar abscess and ultimately took his life. So antibiotics are interwoven with our bacterial diseases are interwoven within our country's history for the last 85 years have become part of the story of American medicine. Dr. Dixon, let me just ask you, because this is such an unusual situation with this woman that had the infection. She had an Enterobacter infection, is that correct? Do I understand the story correctly?
I think you do. It might be better if Dr. Bell, who followed that case and did the case study, could talk about the clinical workup of that individual.
So how in the world did you find this plasmid or this gene that was so unusual? Was there something about this patient's presentation that said we better look for this rare gene?
No, actually, this story really begins with, it's a sort of a case study in how beefing up surveillance can really make a big difference in terms of prevention and response. So since we first heard about this MCR1 identification in China, all of us in the federal partners, including the Department of Defense, have been looking for evidence of this gene. And so the Department of Defense has a surveillance system where patients with bacterial infections or isolates within their system that have certain characteristics, in this case, show resistance to some of the extended spectrum beta-lactamases, are shuttled eventually to the Walter Reed, where they fully characterize these unusual isolates. And it was in the context of that that this was identified.
But there was nothing in the patient's clinical course or her diagnostic presentation that said, oh boy, we better be looking for this one needle in the haystack.
No, that's right. There wasn't. And actually, just to clarify that this bacteria actually is not a pan-resistant bacteria. So the bacteria that infected this patient is actually treatable by some antibiotics. And the patient herself is actually fine. Indeed, we've actually, in our field investigation and follow-up, we've been able to verify that she no longer has that bacteria in her urine.
Well, that's good news, but I guess the other question that comes up is, how do you know this hasn't occurred on other occasions in all of the
Absolutely.
vast number of specimens
Right.
that aren't subject to that type of scrutiny?
We do not know, and I think that's to the point about what are we doing with the investments that are available to us because of Congress's appropriation, is that we are going to be, and this is one of the things I think we've been concerned about for a long time, that, for example, the CDC being the only lab in the country that can actually look for some of these unusual types of resistance, that's not a good state of affairs. And with the additional investments, we're going to be able to have a much more robust system for systematically looking for these and for looking up for other and new emerging forms of resistance. And that's really, in terms of responding to this finding, that's really the first thing that we want to do. We need to figure out how big a problem this is, as you say, Congressman.
All right. Thank you, Mr. Chairman. I'll yield back. Maybe we'll have time for a second round.
Our next is Congressman Green from Texas for 5 minutes.
Thank you, Mr. Chairman. Antibiotic resistance is a significant public health challenge, and we need to think creatively to address it. And I want to hear from our witnesses today about the regulatory and scientific challenge in developing new antibiotics, especially focus on what we can do to tackle them. Dr. Hatchett, what are some of the challenges facing manufacturers in the antibiotics market?
Thank you for the question, Congressman Green. Certainly there are scientific challenges, and I may turn to my colleague, Dr. Dixon, to let him address the scientific challenges. I'm just a dumb oncologist, so this is not my field. But I do understand that the medicinal chemistry, particularly for gram-negative bacteria, which are some of the bacteria that we are most concerned about, is particularly challenging. From where I'm sitting, I think the biggest challenges relate to the economic incentives, in fact, to convince companies to make the long-term investment to do the development. But that wasn't your question.
Well, but that's, what I was trying to get is that we have both scientific challenges, but we also have financial challenges. And because vaccines are not the next miracle drug, in some cases it could be. But Dr. Woodcock, would you like to add anything on the issue between
Well, I
the
do believe
economics
that
and the
I've
scientific?
talked to some of the large pharmaceutical companies, and in the past they have run very broad scientific discovery programs, and discovery means they're looking for antimicrobials, okay? They're trying to find candidates, and these programs have failed. So down at the science level, this is hard, and I think this is where NIAID's investment in the science of determining what are the bacteria like and how do they generate resistance, and what is very important to advance that science, because this is a hard area to develop drugs in.
Dr. Hatchett, these are the next question for you. Is BORD exploring any new ways to incentivize development of these new antibiotics and other therapeutics?
Yes, sir, we are. I mentioned the our use of our other transaction authority that Congress granted to us in the Pandemic and All Hazardous Preparedness Act, and that allows us to work with companies, particularly large companies that have multiple products in their pipeline, and so we can invest in their entire pipeline as opposed to making a specific investment in a single product. That approach has attracted a great deal of attention from large pharmaceutical partners. We have 2 of those portfolio partnerships now, one with GSK, one with AstraZeneca. A number other are actually in negotiations. The companies find it very attractive because it allows them to keep a focus on the development of anti-infectives in a way that makes economic sense to them. So that's very important. There is a emerging consensus about economic incentives that it's going to require both a combination of traditional, what we call push incentives or investments in R&D contracts, as well as pull incentives, the market entry incentives. If you make it to market, there's a guaranteed market, a guaranteed return on investment, potentially a prize.
That brings us to what the GAIN Act from last Congress and the ADAPT Act and this Congress, both individually but also as part of the 21st Century Cures, envision a scenario where more adaptive clinical trials may be used to help drug developers seeking to create the next antibiotic drug effective against drug-resistant bacteria. Dr. Woodcock, can you tell me your thoughts on how the pathway laid out in ADAPT might benefit drug companies in the pursuit of the new novel and antibiotics?
Certainly. Well, after a candidate is discovered and it's for a resistant organism, then you have another scientific problem of how do you find these people who are infected, who are maybe scattered around, and then test the drug in them when they're critically ill and they need to be treated right away. And so doing these clinical trials, even small clinical programs, are extremely challenging. And of course, we want the drug to be used in the most resistant organisms, so we want it to be tested there to see if it works. But those are hard to find, and so you have this big problem. And we are interested in having a limited development program where you'd really have a great deal more uncertainty, but you wouldn't use the drug for sinusitis and otitis media and so forth. This would be signaled that there was only a limited amount of information, but the drug could be used in these desperate situations. And that pathway, we think, would be a reasonable pathway to make the drug available, but with a stewardship signal.
Thank you, Mr. Chairman. I know I'm out of time, but Dr. Burgess, I have sinus and troubles and every once in a while I get an infection. I will not call you for a prescription. I already take everything else.
All right, the chair recognizes Mr. Collins from New York for 5 minutes.
Thank you, Mr. Chairman. I want to thank the witnesses as well. It's always been a concern to many of us, but maybe to answer a question that I know goes through a lot of families when our kids say, I've got an infection, I need an antibiotic. And many moms and dads say, well, no, if you take these antibiotics, you will become antibiotic resistant. And someday when you're older and you really need one, it's not going to work. Contrasted to what we're talking about today is it's not a person who becomes antibiotic resistant, which is kind of this old wives' tale, versus there's bugs that are figuring out a way to become antibiotic resistant. And a person getting one of those bugs, even if they've never taken an antibiotic in their life, has the same risk. Would that be a fair summary?
Yes, Congressman. If I could use that
Yes.
myself, it would be helpful. That's absolutely right, and that's part of the point about how antibiotic resistance is really a problem for everybody, because it's not an individual that develops resistance; it's the bacteria, and these bacteria are constantly replicating, and they share genetic material, and they spread around the community. So this is exactly your explanation is exactly correct, and I've often thought we need a better term than resistance, because people think that applies to them, and actually it doesn't. It applies to the microbe itself. So again, we've oftentimes thought, perhaps we need a better way to explain this to break that old idea.
Well, sure, I
that
mean,
it's
you can
the
actually
person.
have in a family someone who should take an antibiotic, but because of this misconception, the parents are saying, no, 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 no.
Yeah.
We're going to fight this for a few days, fight this for a week, because we don't want you to become antibiotic resistant.
You're absolutely right. I mean, antibiotics, as we've heard, are, they're a treasure, and they're incredibly important. And we need to, when we talk about stewardship, we don't mean don't use antibiotics. We mean use the right antibiotic at the right dose for the right duration, for the right indication. And it is a very important part of our message.
I think that's why these hearings can be important. Now, I've got a question for Dr. Dixon. I understand at Washington State University, and maybe this will translate to Dr. Woodcock, but I understand they have like an E-Band-Aid, an electromagnetic thing that they're going to put on someone. They pass the electric current through. They've now determined that's producing hydrogen peroxide, and if they control this, they've gotten some interesting results as a way to treat bacterial infections and wounds without antibiotics. Are you familiar with some of that, and do you have a comment on, I know it sounds a little sci-fi-ish, but it actually seems to have some possibility.
I understand the question. I'm not familiar with that particular example. It is entirely consistent, though, with our approach of looking at things other than drugs, traditional drugs. So we're looking at exploiting the host immunity in a better way. We're exploiting things like bacteriophage. We're exploiting things like microbiota, using microbial ecology to outcompete and prevent infections, and other alternative approaches that don't provoke the emergence of resistance.
Yeah, I think it makes a lot of sense sometimes to, obviously
Absolutely.
think out of the box. And if you had a chance, you should maybe look into this. It was Washington State University last November, about 6 months ago. The results sounded very encouraging because instead of by guess and by golly, they finally figured out why electric currents sometimes work and sometimes didn't, and it was controlling the process. And it all came down to the hydrogen peroxide at a level of consistency that would say, on Shark Tank, this one might get funded. Who knows?
Absolutely. A lot of exciting things going on out there.
So question for you, Dr. Woodcock. Let's say something like this happens. Now, this is an electrical therapeutic, if you will. It's not a quote, drug. What role would the FDA have, and would you have to run clinical trials like it would be a drug, or is there something else when it's almost like a device or something instead of a drug?
Well, there has to be a determination first whether it's a drug or device, and we have a process that's been set up by Congress and an office that sorts that out. And what has to be done to study it depends on whether it's a device, a medical device, or a drug. And those are appropriate to the two different kinds of
It would be, being one or the other, it would still have to go through your agency for approval, final
Yes.
sign-off, if you will.
These type of therapeutics, whether they're devices or drugs, are regulated by the FDA.
Okay, and no idea what this one would be, but I think all of us are encouraged. There may be, in this high-tech world we live in now, something other than antibiotics. At the same time, we got to keep searching, and it's kind of an all-of-the-above search, if you will. Thank you for your testimony. My time's expired, and I yield back, Mr. Chairman.
Thank you. And we now recognize for the next round of questions, Ms. Castor from Florida for 5 minutes.
Thank you, Mr. Chairman, and thank you all for your expert testimony today. I want to return to the discussion of how we tackle this internationally, as Mr. McKinley focused on, because no single country like the U.S. can do this alone. We're so interconnected now. People travel. You said microbes travel, animals travel, food travels. In July of 2014, the UK commissioned a study on the global problem of antimicrobial resistance. The study concluded that we must be concerned about drug resistance globally if we expect to be safe at home. An important theme discussed in the report is that infectious diseases profoundly affect poorer countries due to unsanitary living conditions. Unsanitary conditions, the report says, act as a catalyst of rapid person-to-person spread, which can lead to an increase in the use and overuse of antibiotics. Dr. Bell, what effect do poor living conditions and access to clean food and water have on the spread of infectious diseases, and how can poor sanitation contribute to the overuse of antibiotics?
Yes, thank you. This is unfortunately very much the case that And you could imagine how, if you think about our prevention strategies in terms of infection control and in terms of hygiene, how countries where people really just don't have the option of the sort of hygiene that we can, the level that we can establish here in the United States, that this does contribute to spread. And we see this in many countries around the world. You know, I think one of the things that we've learned is that I think it makes sense to sort of break some of this down in order to approach it. And infection control in hospitals, for example, is one component that we've really been working now with a lot of countries to at least improve infection control in facilities. If we see that a lot of the most resistant bacteria are in facilities. We've been working with a number of countries in India, in West Africa. You heard with Ebola, that's not about antibiotic resistance, but we certainly saw what the importance of infection control was.
So when poor countries address problems such as sanitation, access to clean water and infections in their medical facilities, I mean, this is basic. That helps reduce antibiotic resistance. And then what more can be done then? We have so many fantastic nonprofit organizations, academics, churches, the developed world. What else can that group be doing to reduce the spread of infection?
Yes, you're absolutely right. And actually, I'll go back again to Ebola, while that isn't a resistant organism. In our work in West Africa to improve infection control, we used many non-governmental organizations, church groups, and other sorts of non-governmental groups as trainers, as extenders, and as groups that, you know, can stay in the area and help the ministries of health and the hospitals with infection control.
So some experts have said, and the UK report said, and I think Mr. McKinley had said what needs to be done, they emphasize kind of some global organizing, collaborative, or campaign. How could we go about such an effort?
You know, the World Health Organization actually is in the process of organizing such a campaign. And while we, you know, we all need to participate in that and provide some leadership.
So that would include tackling the over-the-counter prescriptions of antibiotics. The UK study reported that in parts of Southern and Eastern Europe, 20 to 30% of antibiotics are consumed without a prescription, and in parts of Africa, the figure rises to 100%.
Yeah, that's definitely a part of what we have to tackle.
Okay. And then, Dr. Woodcock, internet sales of antibiotics is a huge problem that this committee has documented extensively. You've testified before that this committee multiple times on the use of internet drugs. What role does FDA believe that internet drug sales have on drug resistance across the globe?
I don't think we know in the United States. You know, we intercept some packages and so forth. Most of the ones that we intercept are not antimicrobials, but certainly that could play a role. But I think that's something that's very difficult to get your hands around because, again, it's an international problem. Some of these are counterfeit, and that often plays a big role, especially in places like Africa or potentially even here, because they don't have the right amount in there, but they may have a low amount of antimicrobial in them, which then promotes generation of resistance. So this is the free flow of antimicrobials, whether it's from over-the-counter use or through the internet, is potentially a continuing large problem and very difficult to manage.
Thank you very much.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentlelady from Tennessee. 5 minutes for questions, please.
Thank you, Mr. Chairman, and I appreciate the patience you all have had with us this morning as we're running up and down. 2 committees, hearings going on at the same time, so we have been in and out, and you've been patient. Dr. Hatchett, I want to come to you. Going back into February, BARDA established the accelerator to support and research and development. And of course, as we've worked on 21st century cures, we've been so interested in that. And then looking at the candidates that you were going to accelerate through this program with drugs and vaccines and diagnostics and move that into development, and for us, then moving it on to commercialization and into the mainstream. I would like it if you could take just a minute and talk a little bit about the specific candidates that you all have put in that, about some of the vaccines or the microbials, some of the alternative therapies that you are reviewing in that program.
Yes, ma'am. Thank you for the question. Just to be clear, the accelerator has not been established yet. We put out the solicitation earlier this year, and we've received the proposals. We had a good response, and we actually are in the process of negotiating with the lead candidates right now. So we haven't made the
When you
award.
say a good response, quantify that for me a little bit.
I believe we had a pre-proposal conference where we had I don't remember the specific number, and I'm under oath, but I can get it for you.
That'd be great.
But we ended up with 5 proposals, which really aggregated, actually, some of the people that came to the pre-proposal conference met each other and then decided to partner, which made the proposal stronger. So I believe we had 5 proposals, and one of the requirements or one of the, I don't think it was a requirement, but we requested it, was that if the people making a proposal to us could leverage the U.S. government funding by gaining access to additional funding, either from other funders or other venture capital entities, for example, that was going to be viewed as a positive. And fortunately, we had tremendous success with that. So we think when we make the final award, actually our investment, which this year could be as much as $30 million, may serve as a catalyst for additional investment coming in from other funders, even other countries that may be interested because of the way we've structured it. Ms. Castor mentioned the July 2014 UK study that was put together and led by Jim O'Neill, who was the former CEO of Goldman Sachs. And one of the recommendations of that study was to create a global innovation fund for antibiotic development. And actually, the United Kingdom and China have already made contributions of about $50 million to such a fund. We think the accelerator will certainly bring in that level of funding. We are committed to providing up to $250 million for the accelerator over the next 5 years, and that could be a major, major catalyst for international collaboration to support this early stage development.
Okay. And what is your expectation once you are able to populate the accelerator, basically? Then how long do you think it will be before we begin to see next generation products that are ready to go to the marketplace?
So the accelerator, as I mentioned earlier, we're partnering very closely with our colleagues at NIAID, and NIAID has a full suite of what we call product development support services that can help innovators in the early stage accelerate their development. Our funding will allow those innovators to accelerate their timelines for bringing these products forward. And so we may be able to shorten the timelines. If those innovators were left to their own devices and left to the vagaries of the capital markets, it might take them many years to bring those products to the point that they would be ready for advanced development. The things that are in the accelerator are not going to pop out of the accelerator right into the marketplace. They're going to be brought to the stage of clinical development,
Right.
which can take several years.
We understand that, but when we look at some of these drugs that are taking 10 years, 12 years to get through the process, and you look at the entire compendium and you look at what goes on with them, the innovators working with the FDA, our hope is that we're going to see your process work and help to push this to the marketplace sooner, that there will be some efficiencies. We know you've got some challenges, but we are hopeful there will be some efficiencies in moving it forward.
Ours too, ma'am. The perhaps relevant example, it's slightly different scale of urgency, but when we have had to respond to events like the Ebola epidemic or to the pandemic in 2009, we were able to push things forward with incredible velocity, and so shorten normal development timeframes that might be 5, 7, 10 years down to even, 9 months, a year, 2 years.
Okay.
I'm
That's
not
helpful.
promising that we can do that with the accelerator,
Right.
but that's the idea.
That's helpful. That's what we want to hear. Thank you. Yield back.
Gentlelady yields back. Chair thanks the gentlelady, and the chair recognizes the gentleman from New York, Mr. Tonko, for 5 minutes, please.
Thank you, Mr. Chair. My good friend and colleague, Representative Louise Slaughter, to my knowledge, the only microbiologist in Congress, has been raising alarm bells for quite some time about the excessive use of antibiotics in our farm animals and feedstock. I know that the FDA has shared similar concerns about antibiotic use and resistance in farm animals. In fact, FDA's Center for Veterinary Medicine has developed a multi-pronged effort to limit or reverse resistance arising from the use of antibiotics in food-producing animals. Dr. Woodcock, I understand that FDA's efforts to control antibiotic use in farm animals are not entirely in your wheelhouse, given where you sit in the agency. However, can you walk us through what FDA is doing to address the nexus between antibiotic resistance and the overuse of antibiotics at the farm?
Yes, as I said in my oral testimony, the Center for Veterinary Medicine has sought commitments from the manufacturers of animal drugs that have important medical uses, and they have all committed to submit supplements that would basically change these drugs to prescription only, and that means they would not be used for growth promotion purposes, and they would need to be prescribed by a veterinarian. They expect, the Center for Veterinary Medicine expects this to occur at the end of the year, the supplement submission, and so soon after that, the changeover could be accomplished, is my understanding.
Mm-hmm. And with that in mind, are we making, in any way, are we making progress in overuse of antibiotics in our food supplies?
That I can't answer, but we could get back to you on that.
Thank you. I would appreciate that. And Dr. Woodcock, how are we tracking how much and what kinds of antibiotics food producers are using, and who's in charge of that effort, and just what is being done?
Well, in speaking to the Center for Veterinary Medicine, I understand that tracking down to that level is difficult right now. We don't have a billing system similar to what we have for human drugs, where we understand what prescriptions are issued for what animals and so forth. So my understanding is that that's a difficult set of information to find out.
And I understand that one concern of regulators is that antibiotics have been used extensively for feed production purposes and not only for therapeutic purposes. So can you describe how antibiotics have been misused in that regard?
Well, there's been a long tradition, as I understand, and I'm not a veterinarian, but I understand there's been a long tradition of using certain amounts of antimicrobials preventively or in food, in feed for the animals, that results in some growth acceleration of the animals. And it's not treating an infection or anything like that. It's simply to put it in the feed, and then the growth accelerates. And of course, they're being produced as food animals, and so that is an economic benefit. That type of use is what's being addressed by the step that the Center for Veterinary Medicine has taken.
And what are FDA and USDA planning to do to address that aspect of the problem?
Well, we expect when the manufacturers will honor their commitments, they will submit supplements, and these will be changed so they cannot be used for growth promoting purposes, these medically important antibiotics.
Mm-hmm. Are there any other efforts that can be made by FDA to control the use of antibiotics in our food supplies?
Well, I think there's always more that can be done, and I also believe that the norm system is very important and probably needs to be continued to be strengthened. I think the value of surveillance just can't be overestimated, because we need to know what's going on. And at the level of every level, from production all the way through to the food itself, that monitoring is extremely important for us to know what's going on.
I think the efforts obviously are very important to the public.
Yes.
And we're at least pleased to hear that there is that kind of review being conducted. But would love to see efforts go forward to make certain that there's every bit of safety and consumer-oriented response so that we can move forward progressively.
Thank you.
With that, I yield back.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentleman from Oklahoma, Mr. Mullen. 5 minutes for questions, please.
Well, I don't know about the antibiotics in cattle, but I know I live on a farm and I'm on 3 different antibiotics as we speak. I literally just got off Bactrim, and I'm on a Z-Pack, and I've got another one that was described to me yesterday. And so to say that they're overprescribed, I thank the Lord for them, but I will probably say you're accurate on that. With that being said, you know, the University of Oklahoma has done a phenomenal job on trying to close the gap on what they call the superbug. And they recently developed a new antibiotic to go after what a lot of people refer to as MRSA, or as staph infection. But even with all that development, Dr. Woodcock, despite the recent success at University of Oklahoma, is there concerns that new drugs aren't being developed quickly enough to help close this gap?
Yes, there are major concerns because the microbes are kind of like the criminals. They're always one step ahead of us, right? And if you expose people and you expose the bacteria to an antimicrobial, some of them will develop resistance. So we need a robust pipeline. We have approved a number of antibacterials recently for MRSA infections, new ones, but the general pipeline of antimicrobials is not robust. It's very fragile. We don't just need very targeted antimicrobials. We need a broad set of antimicrobials for the future. And that's still not happening, although certainly there are discoveries being made.
So with the current crop of antibiotics out there, do you see where we're going to be able to catch up, or we're going to continue to stay behind or get farther behind?
I think we need to be very concerned because it's not the work of a year to catch up. It's a work of decades, and these development programs, Dr. Burgess mentioned Pfizer earlier, they're no longer in this space of development. These development programs were terminated by lots of companies several decades ago.
Due to?
Lack of economic incentives, and the fact that at that time there was, of course, a broad range of antimicrobials available. And even though we could foresee resistance occurring in the future, the return on investment wasn't there compared to, say, cancer or other fields.
Well, Dr. Woodcock, how long does it take, say, a company that's wanting to develop this? How long does it take them from when they start to when they can probably bring a product to the market?
If you start from discovery, probably 10 years.
At the cost of what?
The estimates are very controversial. Many people have said between $1 billion and $2 billion for a new molecular entity.
So is there a way to speed this up? I mean, if we're behind, because my goodness, I can understand why a company would be hesitant to invest $1 or $2 million $1 or $2 billion on an antibiotic, and it takes 10 years to bring it to market, and the success rate is, I'm sure, pretty low. Do you know what the success rate is on that?
For antimicrobials, it's if you start from discovery, it's going to be 1 in many thousands.
One in many thousands.
You start into entry into the clinic, it might be 1 in 10.
So what is the incentive for a company to do this? I mean, I'm thinking as a business owner, I'm going, okay, I'm going to invest $1 to $2 billion, and I'm going to have 1 out of 1,000, let's just use that number, of a chance of it actually coming to market. Is there an incentive? Is there a way to bring this number down? Is there a way to help improve that?
Well, I would also add that we would urge you as a business owner, once you develop this drug, to make sure it's used very narrowly and not widely used, because otherwise resistance will develop.
Well, I agree with that, but you got to get your money back.
I understand
$1 or $2 billion.
I'm just saying that's the market, that's the return on investment problem. What Dr. Hatchett and Dr. Dixon have been talking about are federal government efforts to accelerate this pipeline and ease the barriers to getting, so it doesn't cost so much and the success rate could be
Is
higher.
the FDA looking into this to help ease those barriers, help speed that process up? Because we can all tell this is going to be a major problem, and so it seems like we should be working together on this.
Oh, yes, and we've been doing things for years. We have issued a number of new guidances on new pathways. We're working with outside public-private partnerships on new endpoints, different ways to study the drugs. And then what was mentioned earlier, the limited population use that's in the 21st Century Cures would be another way of streamlining the development programs.
Dr. Woodcock, thank you. I'm out of time.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentlelady from Illinois, Ms. Tchaikovsky. 5 minutes for questions.
This is exactly the conversation that I have been wanting to get into. Dr. Woodcock, your final, in conclusion, you say, it is virtually undisputed that we are facing a public health crisis because of the rise of serious resistant infections and the simultaneous decline in R&D in this area. What I'm hearing is that there's not enough profit in addressing this problem. And that sets my hair on fire. If this is a public health, worldwide public health issue, and the reason that we cannot make progress is because, as have been called, our industry partners are unwilling to do that because there's not enough money, then it seems to me exactly the space then that government needs to step in and deal with this. I mean, I just don't understand. The word incentives, and there may be other ways besides money, I don't know, but what are we talking about here? That these companies are getting out of the business, that the Pfizers are getting out of the business, there's just not enough dough here, when at some point this could be just a worldwide problem of the bug that's going to, kill, I don't know, millions of people. Somebody answer me.
Well, I would say there are two problems. One is it's very hard to discover and develop these.
Right.
Okay, scientifically. And then once you get them on the market, what everyone will ask them is don't sell them. Okay, don't sell them very much because they're too valuable to waste on. That was the paradigm in the past, that's why antimicrobials are so overprescribed, okay, as they were used for minor infections.
Well, can I interrupt for a second? I think one of the other issues that contributes to that problem is TV advertising of drugs, which has created an atmosphere among consumers that I'm in charge of my health, I'm going to go to my doctor, I'm going to say what I want, I'll find a way to get that drug. I just wanted to add that. I think that is part of the culture that contributes to this problem. Anybody?
I also thank you for it's a critically important question, and I have seen an estimate that the market for antibiotics in the United States is about $40 billion, but of that $40 billion for that market, only about $4 to $5 billion is for drugs that are on patent. So any new drug that enters a market where there are dozens of competing generic antibiotics. And so the new entries can't charge a premium unless they can fully differentiate themselves from all of the other antibiotics that are on the market. And so it suppresses the ability to achieve profit for a new drug, and you've heard the estimates of what it costs to bring a new drug to market, and so companies, to recoup their investment over many, many years, have to see opportunities in the marketplace that they can achieve that return, even almost just to a break even. The model that BARDA has implemented in other areas where the market is failing to deliver public health requirements, so against agents of bioterrorism or pandemic influenza, for example. We, over the past decade, have evolved a model where we provide substantial advanced research and development funding for products that have reached the stage of clinical development. So these are things that are being tested in human clinical trials. We also provide a market entry incentive, a pull incentive in terms of a procurement of the product. So for something that we're developing for bioterrorism, we then buy a large quantity of it and put it into the strategic national stockpile. So a person working on it has a guaranteed market commitment. And the other thing that we provide, which is very, very critical, we found this to be extremely critical, is we provide access to a core of experts on all aspects of product development who can assist potentially smaller companies that don't have all of this expertise in-house, and access to product development infrastructure. And so it's a multi-legged stool in terms of the support that we provide. It wasn't until we put all of those components together for our bioterrorism threats, for pandemic influenza threats, that we really started to see our program succeed. We think many of those elements are going to be required to overcome these adverse market forces that are leading to disinvestment.
Well, I hope that bottom line isn't that we have to look at the bottom line of for-profit companies to figure out whether we're going to protect the health of this planet.
The gentlelady yields back. Let me, if I could, I would like to ask a follow-up question, because the Center for Medicare and Medicaid Services yesterday put out a relatively lengthy proposed rule on the stewardship program. Or have you had a chance to familiarize yourself with the proposed rule that CMS has put out? The question is, once again, do we get the right balance between the regulatory burden and effective governance? So, again, I just appreciate your thoughts on the proposed rule.
I haven't actually seen the rule itself, Congressman, but we have been working with CMS around this concept for quite some time. They've already actually had previously issued some comments for a similar kind of conditions of participation for long-term care, and now this is the one for acute care. So I appreciate your point about, a balance between regulation and sort of individual clinical judgment. In general, these conditions of participation, they've been working closely with us, and they basically are meant to incorporate the core principles of stewardship that we published in 2014 for inpatient and 2015 for long-term care. So these are really just fundamental, kind of necessary pieces of a puzzle so that a facility has a stewardship program that actually is able to influence the process. And I will say also that this whole process of coming up with the core elements and CMS's participation has really been very broadly supported in general by, American Hospital Association and by lots of kind of industry partners. I think there really is a broad agreement now that the concept of helping physicians and facilities and patients prescribe wisely is really pivotal. We've been talking a lot about drug development and, what all the gaps are there. But really, and as you've heard, I think this whole issue of antibiotic resistance is a long-term problem. It has many components, and we really have to address them all in order to tackle it. And one of the pivotal components is this issue of stewardship, of getting serious about doing something about overprescribing, not stopping people from prescribing, but being able to preserve the antibiotics that we have now. And that's sort of about saving lives now, as well as these areas of prevention and diagnostics and new drug development. So I think, as I say, I haven't read, I'm not familiar with the specifics, but it has been really a very broad process that CMS has gone through and has collaborated quite closely with us.
Dr. Woodcock, on the issue of stewardship, and you've mentioned in your opening statement in response to Mr. Tonko's question about involving the USDA and the veterinarian space in this. I mean, it's one thing to come down hard on the private practice doc in the United States for overprescribing antibiotics, and I'd probably include myself in that group that would feel put upon by some of these directions. But honestly, we can't compete with what's being used in feedlots.
As I said, the Center for Veterinary Medicine has taken steps around that and secured commitments from those manufacturers of medically important antimicrobials that they will transfer they will submit a supplement that will eliminate that use, basically.
If I could just add that the concept of stewardship and stewardship for veterinarians, in addition to stewardship for human doctors, is something that the American Veterinary Medical Association has been quite interested in. And we've been providing them actually with a lot of tools that they could use with veterinarians. And we've actually, we haven't spoken about companion animals, but this is another area actually where we really don't have a very good sense of what's happening. And we will be looking to establish something there.
I'm gonna stop there. I want to ask one other question of Dr. Woodcock. Since we're speaking about animal products, the issuance of an emergency use authorization for a genetically modified mosquito in parts of the world that are affected by the Zika virus. Why is that taking so long? Why is it so difficult? Why is a genetically modified mosquito having to go through a new drug application?
That is out of my wheelhouse, and we'd have to get back to you on that particular question. It's not a drug.
But it's my understanding is being treated as if it was a new drug application. So I appreciate that's not part of today's discussion, but I really do want to follow up with you on that because I think it's an important issue. Seeing no further members wishing to ask, you have a question? The gentleman from Illinois just wants me to conclude. So I do want to thank all our witnesses and members who participated in today's hearing. I remind members they have 10 business days to submit questions for the record, and I ask all the witnesses to agree to respond promptly to these questions. With that, the subcommittee stands adjourned.